All right. Well, I have the pleasure to introduce our speaker for today's AMSSM ultrasound case series presentation. This is going to be Dr. Connie Hsu, who's a clinical assistant professor at the University of Washington Sports and Spine Department. She did her residency training at Harvard Spalding Rehabilitation in Boston, and then this was followed by a fellowship training at the University of Chicago Primary Care Sports Medicine program. And she is a former swimmer herself, so she's very excited to build a career in swimming medicine to help improve injury prevention and management for swimmers of all ages. And all levels. And today she's going to be giving us a presentation on bicipital radial bursitis.
All right. Thank you, Stephen, for that brief introduction. And thank you to the AMSSM Ultrasound Committee for putting this together. I'm going to go ahead and share my screen now. Okay. All right. So today we have a case about an anterior elbow pain in a home chef. I have no financial interest to disclose. So the goal of this presentation really is to present a protocol-based ultrasound evaluation of the anterior elbow. So first we'll start by presenting a patient case. We'll go over the diagnostic ultrasound protocols for the anterior elbow, discuss the protocol images, discuss pertinent ultrasound pathology from our patient, and then finally at the end we'll review our ultrasound report. So for our case, we have a 68-year-old female with anterior elbow swelling and anterior/medial-ish elbow pain. There is no acute mechanism of injury. She does enjoy cooking, so she's not exactly an athlete, but everyone's an athlete in their own way. She reports that it's intermittently painful, so it's not constant. No numbness and tingling, no prior injury, injections, or surgeries. She was evaluated in our sports medicine clinic. This was back in Chicago. X-rays were normal. They'll be on the next slide. So we ordered a diagnostic ultrasound for her. At the time, her physical exam, she was tender over the medial epicondyle, so the common flexor tendon origin, and she had pain with flexion and supination and mild swelling over the anterior elbow. So the diagnostic ultrasound was initially ordered for common flexor tendinosis, just common things being common. Here are her x-rays. So just on quick review, there are preserved joint spaces, no fractures, dislocations, no obvious enthesophytes. So basically a normal x-ray. I have a slide here just to talk a little bit about anterior elbow anatomy. So it's really important to understand when you're scanning with ultrasound, you have to know your anatomy. So you should be basically able to predict what you're going to see on the ultrasound screen before you even put the probe down. Important structures to note here. The brachioradialis is missing here, but that's an important structure to know. Your biceps, of course, your brachialis muscle, which is under the biceps, your pronator teres. This is your lacertus fibrosis. It can trap the median nerve. And then, of course, your median nerve, brachial artery, and your radial nerve. All right, so this is a list of my complete anterior elbow protocol. Normally I start with my home base, which is the anterior elbow joint on short axis, and I switch to long axis for the anterior ulnohumeral joint and radiocapitellar joint. Then I move on to looking at the muscles, tendons, nerves, vessels, and any other connective tissue, which is kind of like extra credit. So the muscles include, like I said before, brachialis, brachioradialis, pronator teres, and then the biceps tendon, median nerve, radial nerve, and brachial artery. So that's the basic complete exam for the anterior elbow. All right, so moving on to scanning basics. So for this exam, we use the transducer. Normally you want a linear transducer when you're looking at these mostly superficial structures, particularly in the elbow, frequency ranging from 5 to 15. Positioning, you can really do it one of two ways. If the patient prefers to sit, or if you have the ultrasound in a certain part of the room, you can have them actually sitting in a patient chair with their arm on the exam table, supinated and bent from around 100 to 160 degrees until you move them to the cobra view, which we'll talk a little bit about later. You can also have them supine. So in this picture I have to the side there, the patient is lying on their back with their elbow extended. That can also work as well. All right, so we're going to start with the anterior elbow joint. So just a very quick basic review. The trochlea of the humerus articulates with the ulna, and the capitellum of the humerus articulates with the radial head. So this is really my anterior elbow home base. This is what I look for first when I start scanning the anterior elbow. This is in short axis, and you're really centered around the brachialis muscle, which is this large muscle we see right over here. It's important to locate the capitellum and the trochlea. So the capitellum will be on the radial side or the lateral side, which on this image is to the left. And then the trochlea is going to be on the ulnar side or the medial side, which in this image is on the right. It's also important to locate the articular cartilage, which is this hypoechoic line over here, or anechoic, and your capsule, which lies right on top of it. And then here is an image of your elbow, and then this little rectangle here is going to represent our ultrasound. So this next slide, really for people who are reviewing this after, you have your capitellum, you have your trochlea, you have your articular cartilage, and you have your joint capsule identified by that little arrow. All right, moving on to the humeral ulnar joint. So this is on the medial side. So this is a long axis image. So if we take that ultrasound that we had before, now we're turning it 90 degrees. And so this is in long axis. You have your brachialis and your pronator teres overlying this. You'll locate your humerus, that's the trochlea, and the ulna, and the coronate fossa as well, which you can't see in this image, but I'll have another one after this. So there's our ultrasound probe. Our trochlea is here, ulna is here, and then if you slide a little more proximally, you'll reach your coronoid fossa, which looks like this. All right, radiocapitellar joint, similar thing, except it's on the lateral side, or on our image, the left side, compared to the ulna, which was on the medial side. This is also a long axis image. You have your brachioradialis and your brachialis overlying this. Important to locate the radial head, which has a nice little flat surface, so usually pretty easy to find, and then your capitellum, part of your humerus, and then you also should locate your radial fossa as well. So capitellum, radial head, and then radial fossa, which is smaller than the olecranon or coronoid fossa. All right, now we're moving on to the anterior elbow structures. So this includes the muscles, your biceps tendon, and the important nerves that run through this area. So again, moving to home base because everything really starts from here. And if you ever get lost, I encourage you to go back to home base and figure out where you are. So here, the view we have here, like I said, the brachialis is centered. This is short axis. And actually, you can see most everything through this view, which is why I love it so much. So you have your pronator teres on your medial side, which is the right side over here. You have your median nerve over here. Sorry, my clicker is being a little, I think I can see my face on the side too. There we go. All right, so your median nerve is right here. Your brachial artery is right here. Biceps tendon is up here. And then you have your radial nerve over here. And then your brachioradialis over here. So this view is really your money view, where you can find everything and go from there. This is where the ultrasound probe is located. All right, so here's that view again with everything labeled for your reference. Your brachialis, brachioradialis, pronator teres, your brachial artery and your median nerve, and then you have your biceps tendon up here, and then you have your radial nerve over here on the lateral side, which is the left side. All right, moving on to the radial nerve. So I always love this part because it's so cool to see it split off. So you have your radial nerve in short axis. If you scan your radial nerve a little bit distally, it breaks off into the superficial and the deep branch of the radial nerve. At the place where it breaks off is called the arcade of Frosch. And then after it breaks off, if you keep following the deep portion, that's renamed as the pin or the posterior interosseous nerve. Also, your goal is to locate the two heads of the supinator muscle as well. So right here, this image is basically right at the arcata frosch. We wanted to find one right where it splits. But I'll also have a nice picture of the pin located within the two heads of the supinator muscle as well. So here is the radial nerve at the arcata frosch. I have here superficial radial nerve, and you have your deep radial nerve, which is also called the pin. This image is showing the pin in between the two heads of the supinator. So our deep portion is the ulnar or an ulnar head, and then our superficial part of the supinator is the humeral head. And then you see the pin kind of sitting in between those. I believe I got this image with the patient pronating their arm a little bit to make it a little more obvious. But if you scan distally, you should be able to find a view like this. All right, moving on to the median nerve. The median nerve is very easy to find at the anterior elbow. It's sitting right next to the brachial artery, which is also pretty obvious. So here it is right here. This is a short axis view. It's important to be able to follow the median nerve through its course. So that means you'll find it where it is right here at the brachial artery, but also be able to follow it distally until it reaches to around mid-forearm where it courses through or in between the flexor digitorum superficialis and the flexor digitorum profundus. And then for fun, you should be able to follow it all the way down to the carpal tunnel as well. So here's the median nerve, here's the pronator teres, and then just for fun, you can also look at the median nerve and long axis. So we have it right here. All right, moving on to the brachial artery. So this is it in short axis view. Again, it runs alongside the median nerve above the elbow, and it divides into the radial and ulnar arteries. I don't have a picture of that from our patient, but we do have a nice color view, so we can prove to ourselves that this is the brachial artery. All right, now the fun part. So, moving on to the biceps tendon, this is where all the fun pathology is going to be. I have, on one hand, the normal views here from myself, basically, because the pathology was actually pretty obvious, so it may be hard to understand what you're looking at. So I'll show you some normal images first, and then I'll show you what the patient had. So really three views of the biceps tendon. This one is probably my least favorite, which is the biceps tendon in short axis view. When you scan the biceps tendon from that home base anterior elbow more distally, there ends up being a lot of anisotropy, and it's really hard to follow it all the way down without it disappearing at some point or becoming dark. But at this area, you can still kind of see it. There should be a bilobed appearance representing the short and long head of the biceps. It runs alongside the brachial artery, which is a good point to find. The short head is usually more medial, long head is more lateral. And the reason why it tends to disappear is because it's diving deep to attach to the radial tuberosity. So like I said, this short axis view is not my favorite, but it's good to practice anyway to see it attached to the radial tuberosity. This one actually is my favorite. So this one is the pronator view. It's a long axis view of the biceps tendon. Your arm is positioned at 120 degrees-ish, so somewhere between 90 and 180. You want to start at the medial epicondyle and translate your probe towards the mid forearm. What you should try to identify first is the brachial artery, and then below that you should see the long axis attachment to the radial tuberosity. So here's the brachial artery right over here, and you can also prove that to yourself with color. And then below that is your biceps tendon, which attaches to the radial tuberosity. This to me is the most intuitive view, which is why I like it, but it can be difficult to find at first. All right, and then the last view of the biceps tendon, which is kind of our injection view as well, is the Cobra view. So with this, your elbows flex to 90 degrees, actually maybe even a little more, and then pronated. So right here is a very low resolution image of what the Cobra view would look like. And your biceps tendon should be located in between the radial tuberosity and the ulna. So this little slip right here, that's what it is. And here's the image again, just blown up. All right, and now we have our patient images. So here is a long axis and short axis view of what we're looking at. So we see the biceps tendon right over here in long axis, and then we see this pocket of fluid kind of around it. Hard to tell from this image if this is the brachial artery or if that's fluid, but we definitely see fluid at least underneath the biceps tendon. To clarify, you want to look at two views. So we turn the probe to short axis view, and we can actually see that the fluid surrounds the entire biceps tendon. And here are some more images that prove that to us. So more views, biceps tendon kind of sitting in the middle, and then you see the fluid all around it. And then above it, right here, is our brachial artery. And these are just some measurements that we took of the bicipitoradial bursitis. So really cool images, but you just by looking at these, you might not be able to tell exactly what you're looking at, which is why I wanted to show you guys some normal images first. Just for fun, just for extra credit, Dr. Verma and I were trying to look for the Lacertus fibrosis. It's a place where you may potentially trap the median nerve. It's a thin hyperechoic band usually. You should try to identify this by looking for the brachial artery because it's so easy to find, which is right down here. And then sometimes you can find a basilic vein superficial. It might be here. But we believe that this was the Lacertus fibrosis. So we were just doing this for fun. I don't know if there's any diagnostic utility for this, but it's good to practice stuff like this. All right, so wrapping up, this is our full ultrasound report. So we have a normal, basically most things are normal. Your ulnar-humeral joint, radial-capitellar joint, brachialis muscle, brachial artery and vein, median nerve, radial nerve, brachioradialis muscle, until we reach the biceps tendon. So at the distal biceps tendon, we see a moderate to severe hypoechoic heterogeneity and thickening near the insertion at the radial tuberosity without evidence of a full thickness tear. There is an anechoic region surrounding the distal biceps tendon just proximal to the insertion, measuring 2.85 by 1.86 by 1.61 centimeters. There are no hyperemia, internal debris, or septations within this anechoic region. So that's all that fluid that you saw surrounding the biceps tendon. Of note, the distal biceps tendon is visualized within the anechoic region on both short and long axis views. The brachial artery is adjacent but anatomically distinct, and there is tenderness to sonopalpation directly over the distal biceps tendon. So our overall impression is that there is sonographic evidence of a right distal biceps tendinosis with associated bicipitoradial bursopathy. Otherwise, normal ultrasound exam for everything else. And just to wrap it up, we wanted to talk a little bit about how the patient did. So a week after her ultrasound, the patient elected to proceed with a bicipital radial bursal aspiration, yielded 3 cc of clear serosanguinous gelatinous fluid. We, definitely want to use ultrasound for this because the brachial artery is right there. So you want to be sure that you know what you're seeing. 2 weeks after the aspiration, the patient expressed temporary improvement, but her symptoms returned. So we ordered an MRI to further assess for potentially, we saw an ultrasound that there wasn't a full thickness biceps tear, but we just wanted to make sure. And this showed severe distal biceps tendinosis with scattered low-grade interstitial tears and fraying, but can't exclude high-grade partial thickness tearing with granulation tissue. And then they also noted a severe bicipital radial bursitis. So here's the MRI scan, very, very clear. This bright white here on this T2 image, that's the fluid. And over here, same thing as well on our axial image. But fortunately, some things tend to fix themselves. So Follow-up after MRI, so 7 weeks after her aspiration, the patient stated that her symptoms had completely resolved. So she elected to pursue observation with activities as tolerated and follow-up as needed. So in conclusion, the human body is wonderful and can heal itself sometimes. Take-home points for today's presentation. Systematic approach is very key. So start with a joint, start with home base, right? If you get lost, return back to home base because most everything you want is actually right there. And then you can follow it from there. Atraumatic swelling over the anterior elbow warrants a high degree of suspicion for chronic distal biceps tendon pathology, or you might want to look at a vascular etiology as well because the brachial artery is there. And beware of granulation tissue formation when history indicates chronic tendon pathology. And I just want to thank my PDs and my mentors at the University of Chicago for helping me with this presentation and encouraging me to study more ultrasound, which I love. So Dr. Verma was the driving force of this presentation and allowed me to help out with this patient. So thank you so much. And thank you to Dr. Labrador, my program director, Dr. Benjamin, who is an amazing mentor and would talk with me about swimming medicine all day, any day. And to Dr. Brendan Ross, who is PM&R trained and was a rock throughout the year. All right, that is it.
All right. Well, thank you so much, Connie, for that excellent presentation. So just a few comments, then we'll kind of open it up for any other questions as well too from the audience. One thing I was going to emphasize, for the protocols you had mentioned, I think it's always helpful to kind of rule out, especially if you're seeing a fluid collection in the elbow, would be looking at, an elbow joint effusion. And you had kind of mentioned the anterior areas that you can look for those. I do think it can also be helpful to still look posterior as well to the posterior elbow joint, just because that's where I've seen it to be most consistent to be able to evaluate that. And just looking in the olecranon fossa, as well too. Just if you're not seeing a lot of fluid, that can be just one other area that you can kind of almost triple check just to see if it potentially is then an elbow joint effusion. Something else you had already mentioned, just, for the biceps and this bicipitoradial bursa, there's many different views that you can do. So you got to get comfortable at using all of these, I think, to get a thorough evaluation of that area. And as you had mentioned, I think the pronator view is just really good at looking at the insertion of the distal biceps, especially the long and the short heads, which sometimes can get affected differently. But then obviously you had demonstrated the Cobra Kai view, which I think a lot of the time can for sure fully demonstrate that bursa and if there's any type of bursal distension at that area. And then lastly, I just wanted to mention you had kind of added the Lacertus on that last slide, which is one of kind of those more atypical structures that we don't always include. But I'm glad that you did, because I do think the Lacertus can have a lot of concurrent, pathology with the distal biceps, just because it will obviously be typically inserting onto the short head of the biceps or originating from that area. But sometimes it can also go to the long head as well too. And with that, if you have the distal biceps tendon tears, this is where I found that knowing about the Lacertus can be helpful, because in some of those distal biceps tendon tears, you will actually have then tearing concurrently of the Lacertus. And if that happens, that's usually where you have pretty significant retraction. But in some other atypical cases, you may actually not tear the Lacertus. And so then that sometimes can be confusing, because you do see, a biceps tendon tear, but you don't see it fully retracted. And that may be because the Lacertus is still intact or still intact to a portion of the biceps, which sometimes can be that short head. And obviously that can be helpful if these patients are needing to go on to surgery as well too, just because sometimes they have to do augmentation of the Lacertus for the repairs as well too. So I'm glad that you included demonstrating, evaluating the Lacertus, just because it can be very helpful, especially if you're seeing those distal biceps tendon tears. So, but those are just some of the comments I wanted to make, but obviously we'll start to open it up here.
Yeah. Hi, this is Doug Hoffman. Connie, that was a great presentation. And I love the fact that you start with the joints and your home base. I think at any level of experience of ultrasound, starting there is always useful, and going back, as you say, you get lost, you go back to your home base or what you know, and then work through from there. So I love the fact that you started your presentation there. You mentioned the short axis view of the biceps, and I agree, it can be a frustrating view. I've learned over time, though, that some proficiency at scanning that view can yield information that the long axis sometimes can underestimate. And so by obviously adjusting for anisotropy with wagging the probe, but also either towing in laterally or a medial to lateral tilt of the transducer can now orient the transducer a little more parallel as it comes and takes a deep dive and actually mimics the MRI in that axial view. And so with that transducer manipulation, I have found that the views for the short axis become more clear. And particularly in the short axis view, you can see the short head and long head much better. But in terms of a bicipital radial bursitis, clinically for me, where that's been useful is I can see a small amount of fluid in that bursa, particularly when evaluating a partial tear of the distal biceps. So in that short axis view, if I do see most commonly anechoic fluid, then my radar goes up for, okay, I think there's a partial tear there, or more often than not, there is. So I just have found that view useful to get proficient at in looking for small amounts of fluid in the bicipital radial bursa. And of course, if you pronate the forearm, you're going to squeeze out fluid in that bursa distally because then the tendon wraps around the radius. And then if you supinate, it opens it up. So I just have found that a little more useful clinically to do that. Stephen, I'm glad you mentioned the Lacertus. I mean, I tend to report out if whether an Lacertus is intact or not when I see a distal biceps rupture. I'm curious, obviously, Stephen, I think based on what you said you do other people, I do report the Lacertus, whether it's intact or torn. Do other people do that?
Yeah, Doug, I was going to say I've started to because after seeing a few of these cases where the Lacertus wasn't torn, in some of these cases, that I've started to report that, especially if there's a degree of retraction, just so that they're aware for surgical purposes. And I've had a few of the surgeons send me specifically to look at that further because it wasn't clearly delineated on other imaging.
Hmm. Yeah, and that's where the dynamic capabilities of ultrasound are helpful because Lacertus becomes more conspicuous as you scan proximal to distal and back, because then you'll see those very superficial hypercoic fibers essentially go over the pronator teres and then blend in with the aponeurosis.
All right. Well, unless there's any other comments, we just got a couple in the chat that say great job, Connie. Otherwise than that, if we don't have any other questions, then we'll conclude today's presentation.
Great. Thank you.